from a LZ report or even a patient report, what information are you guys looking for? Obviously, we talked about weight, we talked about obstacles at LZ, but what other things are you looking for in that report?
Let's start with clinical brief first, and then we'll talk about the LZ brief.
Clinical brief, there's multiple formats to use, like the MIST format, but ultimately we want to know what's wrong with the patient. Most importantly, if it's a trauma, what's the mechanism? What's the height of the fall? Obviously, the patient's age or status, whether they're if you have to estimate them as 5-year-old pediatric and they're 10, that's
not a big
life.
deal.
That's how it is.
Right.
So it's more adult versus pediatric, because that'll determine what we're kind of briefing ourselves for in the way of medications or what
Gear,
we're going to give or gear we need to grab. So, like I said, mechanism or injury, the patient age. The second big one would be any kind of airway status. That is a big one for us. If you're anticipating an intubation, we want to know about it. If you're saying the airway's intact, the patient is talking to us, or the airway is intact, patient's on 99% on 2 liters, but they're very altered with a head injury, that's giving us a little bit more history, a little bit more preparedness for when we get down there. The other thing would be vital signs would probably be like the very last, especially if it's what we're very interested in is startling vital signs. They are 78% on non-rebreather. The patient
has no measurable blood pressure.
Right. Yeah. It is 660 over palp, or the patient is tacky at 200 and it's VTAC, or we're talking startling vital signs. I don't think any of us would have a problem if the patient is alert oriented talking to us and you say normal vital signs. I'm generally fine with that.
Yeah.
But we want to know the startling stuff. Another big one is we want to know if the patient is altered. We want to know blood sugar. Try to get a blood sugar.
I call that the 5th vital sign. So
100%. Yeah.
Yeah. So
You've never once said that.
Never once.
You just thought of that, didn't you?
Yeah. Came to me right now.
Right there.
I love it.
Yeah.
Yeah. There's
We should do a podcast on that.
there's just certain things that that help us determine where we're going and what we're doing with this patient. If you're saying patient has a laceration, patient has a tourniquet, patient has a penetrating injury to their thigh, like those are all things that we could start downtown or whatever trauma center we're headed to. We could start letting them know.
Yeah.
Like this is
penetrating chest trauma with a chest seal in place.
Right.
Yeah.
We could call them up and say, this is going to be we are landing at a scene. We're going to be at you within, 30 minutes or so. We have a patient with an amputation to proximal to the elbow.
All right.
Like that affects what they're going to be calling out, who they're going to get,
specialties.
right.
They'll need.
They're going to start
absolutely.
getting teams prepared down there, and we can let them know, and we can hit them up very early and say, this is what's coming your way. Clear the bay out and call the people because we're coming.
Yeah, true.
And so it's those kind of injuries, like I said, it's important for us to know. So in my mind, patient age, not specific age, pediatric, adult. Obviously sex helps with our measuring for some of our ideal body weight. But other than that, it's like the mechanism and the injuries and any kind of startling vital signs.
I'd probably add into there even some interventions. Did you get lines? Did
Right.
you
Can't get an IV.
Yeah.
Are you throwing tourniquets? Are
Yeah.
you are you darting chests?
Are we giving fluids? Did we give TXA? Are they anything?
Sure.
Anything as far as
Right.
anything's helpful really.
There's definitely a difference between somebody who's 98% SpO2 on a non-rebreather after you've decompressed them.
Right.
Yes.
We'd like to know that. We'd like to know
There's
that.
one important point in that
Right.
in that discussion.
One makes me think that the patient's going to be all right. The other one makes me think that we might have to do some more work.
There's going to be work to be done, right?
Right.
I think one point I want to make with that too is I would go to say that from all of the scenes that we've done between whether it be Geauga, Ashtabula, Lake, Trumbull, Cuyahoga, Portage,
Our catchment area.
our whole area, I would say our EMS providers are excellent. They set us up for success every time we go to a scene, and we're eternally grateful for everything that they do. Being able to get there, and we already have IV access, and hey, we gave 2 grams of TXA already. That helps us so much. It makes things so nice for us, and we're just beyond grateful for that.
I'll get back to the LZ brief in just a second, but let's build off that a little bit more. So that being done,
when we're talking, I guess what I want to add in about age is broad strokes, right? A 2-year-old, a newborn is different than a 2-year-old.
Yep.
A 2-year-old is different from a 5-year-old. 5-year-old is different from a 10-year-old.
Right.
Different than a 15-year-old. But then you get to like decades, right? I got someone in their 20s, 30s, 40s is different than 50s, 60s, 70s, or even different than 80s, 90s, 100s. So it's those ranges that we're talking about.
Somebody might land on scene and think Scott's 35 something years old.
Good enough.
I'd be like, you're my best friend.
But again, a 35-year-old is different than a 2-year-old, or different than a 90-year-old.
Yeah, even getting into the blood pressures and that sort of thing,
Correct.
and you start to get in pathophysiology of aging, and
So I might look 35, but I got physiology of a 75. And I got the medication list to prove it. But so you got your point, and then my point there was before we headed to LZ brief stuff. You said you're eternally grateful for all that stuff being done before you get there. And specifically, airway management was the one thing that I wanted to say. And there's this view that the air medical community, it's not just you guys, but our airway cowboys, and they want to take every airway because they can, right? But there's more to that.
Totally.
Yeah, there's a lot more to that. But let's hit some of the broad brushstrokes to that stuff. We'll come back to the LZ briefs.
Yeah, so actually me and Dr. Hill had a great conversation about this when I was doing my clinical time at Portage regarding knowing when to act. And I think it's even more important, like you said, when not to act.
Right.
I mean, sure, we could go and put a tube in everybody. Is that really the best thing for all of these people?
Right.
Not at all. I think that's just, it's super important for us to know when it's important to do something as well as when not to do something.
Right.
So we're very tactful with our airways, and we're very, I know that getting in a tube can be a scary process. It's especially if you don't do a lot of them, or it's
Or everyone's watching you.
Yeah, you could,
or it's a friend.
Yeah, you could have a million situations going on.
I think on the helicopter we have a couple more considerations for airway, and I've intubated more people, and probably people who I wouldn't have intubated going
on the
into
ground.
a squad, and for some very specific reasons.
Talk about those.
One is our safety. I'm sure there's a lot of people who will watch this who have fought with patients in the back of the squad.
Never once.
Right? Cleveland Saturday night.
You
could expect to
only fight.
have some moments with patients in the back of the squad.
Right.
We can't do that.
You can't,
and it could be very dangerous.
Right.
That patient who, I might have back in the day been like, okay, you're so combative and you want to jump out the side door? Well, slow the squad down and get it to a stop, and
let 'em out.
we will let them out, and we will get some help, and we will contain this person in a safe environment instead of being trapped back here with them. There's no getting out of the side door when you're flying in a helicopter.
You can't do that at
So-
2,000 AGL.
Yeah, 2,000, 3,000
So it's either
foot's, that's a
it's
long
either going to
drop.
be a tragic news story as the patient jumps out of the helicopter,
Sure.
or we will just continue to either get beat or serve beatings in the back of the helicopter till all of us calm down.
Unfortunately, it's not really condoned for us to give the beating part, so it's something we refrain from.
Help them lay down on the cot and be comfortable. Put it that way. Help them lay down. But you can't do that. It's not good for the patient. It's not good for you.
Yep.
It's not good for the aircraft. It's not good for the pilot who's trying to negotiate
whatever
air
you're gonna
traffic
run into, yep.
while he's listening to everything going on in the back. There's a whole level of emotional distraction
Yep.
that he has to worry about his safety now with just a curtain between him and us.
Yep.
So that's the first way, intubating them for our safety and ultimately their safety as well. We've had to do that. One of our flight nurses, Mike, has a good way of putting it. Is he said whenever a patient has either intentionally harmed themselves or intentionally harmed someone else, he spends a good moment just evaluating that patient and their temperament and their mindset before he will do anything with them. Because if they hurt somebody else or if they hurt themselves, and it's that mindset continues onto the helicopter, that's a big danger for you.
Yeah.
At that point, it's less detrimental to sedate that person, to intubate them, and then excavate. I'm not going to say it correctly. Take the tube out.
Remove the tube.
Later on down the road, it's not going to cause them. It's going to cause them far less harm than them being in hard or soft restraints, fighting for 20 minutes on the cot to get free as you're flying downtown. As well as if they're altered, they're scared by the noise, they're scared by the different environment, they're scared by the turbulence. Sometimes it's just safer for them and you to do it. The other way is airway protection. Airway protection isn't just, whoa, we picked up this patient. It was a pedestrian hit by a truck, and they have blood in their airway. We're going to intubate them. For us, we fly the strokes. We fly people who are they have traumatic injuries, but they don't quite need airway protection, but they're vomiting a lot. Now you have to do something, because the last thing you want to do is be behind the ball, because you can't sit there and say, hey, partner, pull over the squad. We need to intubate this person. Now you're doing it in the aircraft, and meanwhile you're up flying above Geauga County with the pilot swerving for every eagle and hawk that comes by, and you want to talk about not setting yourself up for success on the tube. That right there is setting yourself up for not success.
One of the things that I've talked about recently with this is anticipated course, right?
Yeah.
If it's a trauma patient who's got a mangled extremity, or they're internally bleeding, or you think there's some major injury there,
where might this patient wind up?
Absolutely.
They're going to stop by the ER. We're going to bless them, maybe take them to the scanner, or maybe they're going straight to the OR. And if that's the patient's ultimate destination, it's just easier to take that airway on the side of the road, secure it, and fly them.
100%. Yeah. I think even a third, fourth point you could get to would be maybe some unconventional modes of oxygen that maybe aren't feasible in the aircraft. I know we're working towards some of the new Airvo 3 systems that have the batteries that are connected to them that make it easier. But some of that gets kind of difficult, especially if they're on like high oxygen requirements, because our aircraft only holds so much oxygen. And the tanks are only so big, and it's not like you're in a squad that has two massive tanks. It's one average sized tank that, we only got so much oxygen. We're only going to go so far. So if we're going to tube them for that, I mean, you're saving yourself from running out of O's halfway to Cleveland or halfway to wherever you're going, and just makes things a little safer for them, safer for you. I
think it's careful not. You got to be careful not to overdo it at times, because if you're sitting there and you have a neuro patient, and that patient has deficits, they might have some nausea and vomiting, but they have deficits, and they just gave them TPA, and they're trying to look for improvement in that stroke. Do you automatically just pull out your meds and you tube them and say, well, they're going in a helicopter and they're vomiting, we're tubing them right now?
Right.
Well, no. You repeat your antiemetics, you go to your second line, you go to your third line, because that's very important to get them downtown or get them to a stroke center, and now they could evaluate them and
Still
say,
be-
are
yeah.
they improving? Are they not improving? Are they getting worse? Are they going for thrombectomy? What are we doing with them?
Yeah.
You know, it's important to follow, as Dr. Hill said, follow your course of care. If you're sitting there, you know, just recently had a patient with a lot of bleeding in his airway, and that's what we got called for. It was a lot of blood in the airway. It was in his mouth, in the oral cavity. We didn't intubate that patient. We gave the patient, he was alert and oriented sitting there. We gave him a Yonker catheter and hooked it up to our suction and said, hey, stick every time you get a mouthful, stick it in there. And
Clean it out, yeah.
that's exactly what he did. We packed it as best we could, gave him the suction catheter, and said, have at it, buddy.
Chew on
And-
this TXA-soaked gauze.
Yep.
Suction as necessary.
Actually, they did something I haven't seen before, which was nebulized TXA.
Yep.
Yeah.
I hadn't seen that before. They put the TXA in a nebulizer and had him inhale it.
Inhale it. Yep.
And it worked to slow it down. But yeah, it's just like I said, if you go off very just generic stuff, oh, the patient's vomiting a lot. Well, have you tried first line, second line, third line
Yeah.
to get them to stop?
Yep.
Oh, the patient's bleeding in their airway. Well, can the patient suction it out themselves? You know, it's stuff like that where you might spare yourself an airway and spare them an intubation.
Correct. Kind of circling back, we wanted to talk about the LZ briefs. What are you and the pilot listening for in that LZ brief if you're bringing somebody in bringing an aircraft in a sea flight?
Yeah, totally. So as far as our LZ briefs go, really we want to know where are we landing, just a general depiction of the scene. Like I said, poles, wires, trees. Are we next to the accident? Are we down the road from the accident? Are we going to have to take a squad once we get there to
Sure.
go to the accident? Is the squad coming to us?
Coming to us, yep.
We could even get to the point that, you know, are you going to be on that scene long enough that is it worth setting up? Should we rendezvous with you at the helipad?
Elsewhere,
Yeah. Should we rendezvous at, you know, one of the local ER helipads to make things easier, you know?
For everybody, yeah.
Yeah, and if
Or
things
airport.
or an airport for bad weather days, you know, we can IFR out and
Is
get
it
our way back to wherever we need to go.
is it important for them to give you estimated wins? I know that there's some programs that have asked for that, and others are indifferent.
Yeah, so that's kind of, I would say yes and no. It's beneficial information, but not always. So our aircraft are equipped with systems that are able to tell which direction the wind are coming from. And it's one of those cool things that our pilots teach us too. So not only can you look at trees to see if it's windy, and you're not going to get a good idea of the direction the wind's coming from with a tree, but obviously, you know, there's flags out there. There's other things out there. We can even look at, is there a pond over here? You can tell which way the wind's coming from
ripples,
by
yeah.
the ripples and where's the flat spot at. So, you know, that's really, we don't really need to know the wind. But, I mean, if you're able to tell us, sure, it's not going to hurt us. Yeah,
Helpful if there's exceptions for sure, I would imagine.
yeah,
right?
totally.
It's really blustery down here, right? Because
Yeah.
your experience at altitude might be different than
Yeah, but we don't expect you to go out in the field with a windsock and
or a kestrel
and
yeah.
a meter, so you can tell us it's coming from the northeast
Yeah.
at 50 miles an hour.
I know there's been some emphasis put on that historically, which is why I wanted to bring that up.
Yeah, totally.
But it sounds like technology today is different than, and that's dating me a little bit but I remember that being a thing early on.
Oh, you're not
Yeah.
35?
I also am not 35.
Yeah, these aircraft we fly in, they're excellent. I mean, they're so technology advanced.
Yeah.
All the GPS systems, the 4-axis autopilot. If you're sitting there in the front seat, you can actually sit there and watch our pilots take their hands and their feet off all the controls.
What are you doing?
Yeah, and you're like, what are you doing? And they're sitting over there, and they have a little knob, and it literally looks like a little volume knob, and they're just twisting it, and that thing's controlling which way we turn. It's controlling, you know, are we going up or down? They hit a couple buttons, and this thing just flies itself. It's amazing.
Yeah, that's so cool. So
Yeah.
cool.
That being said, when we're landing on a scene, the pilots pretty much are always, hey, do you see a flag in somebody's front yard? Do you see? So if they have those visuals, like you said, if you go to a hospital helipad or an airport, There's always a windsock.
Always
There's
windsock,
for a
right.
reason.
Yeah.
And when we could get into the whole thing of how to tell how fast the wind is going from a windsock, but you could take a look. They'll take a look at, okay, there's a flag in somebody's front yard, and they look at that flag and they're like, it's half out.
Yeah, right. Yeah,
We're good.
get
And
a
it's coming
mental model
It's
of
coming from the west. We're going to come in right here. If it's, that thing's straight out and it's coming from the north, and now we're going to have to come in steep over power lines, it affects how they're going to be setting up for that landing.
for the approach. Huh?
So it's, like I said, it's one of those, it's a kind of like getting a patient exact age. It's helpful if you got it.
Yeah.
If you got it, you
Close is
tell
good
us.
enough, kind of.
Yeah.
Yeah.
I'll even kind of like going back into that where Nate was talking about coming over, say you have winds, and now we have to go over the power lines. One of the reasons we're not going with the wind compared to going into the wind is I was talking earlier about that vortex ring state or settling with power. So when we're coming into the wind, that rotor's spinning and it's pushing air down, and when that wind's, you're going into the wind, it's pushing that dead air behind you.
Behind you. Yeah.
But when you're coming with the wind, what happens is that dead air starts to recirculate, and when it recirculates, you're not going to get your lift anymore. It's
Right.
going to drop you. So that's why it's so important for us. That can cause huge issues. It could cause us to pretty much drop out of the sky. So, yeah, that's why we're pretty dead set on knowing what the wind
pretty
is.
wound up about that.
Yeah, right.
Yeah.
So I'll make a plug for our website and what we'll do instead of discussing it here because it's better with
Visuals.
Visuals.
Yeah, absolutely.
Prehospitalparadigm.com for the show notes. We'll put in flags and how far
Wind
they're out
socks
and
and,
Cool.
wind estimations if people want to look at it. We can do wind socks and just a regular regular
We can
flag.
put all kinds of graphics in
Yeah,
there.
sweet.
One of the things, let's build off of what your point about rendezvousing at places other than the scene if it doesn't make sense. This seems like the perfect segue into talking about IFR versus VFR, what that means, and so let's just tell me about the definitions first, and then we'll talk about what that means if I'm the provider on the ground calling you in. It's if we're doing scene work kind of mindset here.
So you wake up on a beautiful day, sun's out, couple puffy clouds.
Right.
That's true what we call VFR conditions. You could get up in the helicopter, you could see where you're going,
Right.
you could see where other people are coming from. There's no problem.
The V
So VFR is what?
is
Visual
right.
flight rules, and that's if you could see it, that's
Safe to fly.
safe to fly.
Got it.
Yeah.
Conversely,
Yeah.
Everyone's
Conversely,
favorite rules to fly by.
yeah, we can get into IFR. And even before we get into IFR, we can get into marginal. So marginal flight rules, that's when it's starting to get kind of in between there.
Dicey, yeah.
VFR and IFR.
Right.
So we'll talk about IFR first. So IFR is instrument flight rules. So if anybody's ever followed our social media or anything like that, they'll see these videos we post on occasion where we're flying in the clouds.
Right.
It's awesome.
just white it out.
Yeah, it's like literally just throwing a sheet over your face. Like all you see is white.
I don't
It's,
classify that as awesome.
Yeah,
It's-
we have different interpretations of the word awesome.
It's scary when you do it the first time.
Sure.
But the more that you do it, it's a really
course.
cool process. And it's awesome to see our pilots do it. The way that it works is our pilots are using the air traffic control towers, whether that be Cleveland Hopkins or Youngstown or Akron or wherever it may be.
Where are the flying?
Yeah, we're using these towers. We're using the air traffic controllers there are talking us through step by step where to go. And they're looking down at their panel.
Their instruments, yeah.
Yeah, all their instruments right there. And those instruments are telling us, are we level at flight? What's our altitude? What direction are we going? What's our heading? And air traffic control might get on there and say, I need you to turn a heading of 27 at... There they go with that little knob again. Yeah. Yep, twist the little knob, turn that way, and we're heading that way. And basically, so we're not seeing anything the whole time we're flying IFR until we break out. And then there's different restrictions for altitude levels in IFR.
Oh, got it. Yeah, got it.
Flight conditions. And it really varies day or night, that sort of thing, and depends on your your terrain, if you're in mountainous terrain, if you're in flat level terrain. So that all kind of comes into factor as to when it's considered IFR or not. Generally, our area is daytime 805, I believe, and our nighttime is 1,003. So 1,000-foot ceilings, 3 miles visibility. We have to be able to see at least 3 miles out. But when we're coming in, say we're flying IFR, we're flying through the clouds to get somewhere. We're flying airport to airport. That, for the most part, is where we're going. There's very limited places around here that have IFR, maybe pins approaches that we can get into a hospital. I think there's 2 in the area,
Right.
but it's very few and far between. So on a bad weather day, we may ask you to rendezvous at the airports. That way we can get them out of a bad weather area and into a better weather area, or to go from one hospital to another.
Or just or close that distance because they need to get to a closer trauma center or
totally.
to whatever. That was the point that I really wanted you guys to hit, and I'm glad you did, right, is all programs, including ours, right, tout that we, do this IFR stuff, but that doesn't mean that, I can look at Google Maps and say, here's my coordinates, land here. That's not what that means, right?
Yeah, totally.
That means you have to have very established fixed points, and we were talking off camera about how, on an IFR approach is to set that up and establish that and publish that and get all of those parameters. That's not just somebody walks out there with a GPS and says, oh, yep, it's good. It's a lengthy and a very expensive process, hence your comment. There's very few places in this area that...
And it's... even getting into
other
IFR,
than airports, right?
As far as that goes, like our altitudes we're flying at when we're flying IFR, they're generally way higher than we're flying in a VFR day when we can see everywhere, because you got to think about all these telephone wires and all this, whether the terrain is there a hill over here that we could run into. So
cell towers, broadcast towers,
and some of these towers, if you look at even like Parma, those Parma towers are huge. Those are massive.
Yeah.
So that's something we got to take into consideration when we're flying.
Yeah,
and
Parma is a suburb of Cleveland, for our net, and there's a ridge. There's literally a ridge, and there's monsters.
Highest point in Cuyahoga County is up in
indeed
that
it is.
Parma, Broadview Heights area.
Yeah, absolutely.
I think one of the, especially for people who are not familiar with aviation but are familiar with fire and fire EMS, best way I could describe it is if you go into a smoke-filled room and the room is clear, you could see objects, and you could kind of feel your way through it. That's marginal weather. You're kind of coming through the fog. You could see the objects. You could see what might get you in trouble, and you could find the victims. You could find the door. You need to do whatever you need to do. Visual flight rules is you come in and for a down person, and it's a clear room. There's no smoke at all. Yep. And then IFR, true IFR, is that oriented search, where you crawl in, you go in the windows, and its visibility is nothing. And you have your lieutenant or your captain with the thermal camera, and he's watching you. And we call that the oriented search, right? Where he's sitting there, and he's watching everybody on the camera. And he could tell you, all right, turn a little bit. I see a victim under the bed. You could crawl a little bit left. Okay, you're right on top of him. And that is control for us. So that's what control is doing for us. They are helping us navigate through either obstacles or dangers or get to where we need to go. So that would, like I said, there you are in firefighter terms. So.
No, I think it's a very good analogy. We've spent a lot of time talking about the scene rendezvous and the scene work, which most of our audience is most familiar with, but that's not actually the body of your work. What?
Yeah, probably about 80%. Well, it kind of depends base to base, but
base to base, season to season,
it's
program to program. But let's just talk about
for our program.
Probably most of it is cooking dinner.
Yeah.
Did you wait until I took that drink?
It's a very important part of our job.
You and firefighters.
Yeah, we're about probably 80% in our facility.
Yeah.
We're doing hospital trips just for could be. Really, it's a number of reasons. I think one of the biggest things that's a benefit to us is we're fast.
Yeah.
We're great for time sensitive. You got somewhere that's out in the middle of nowhere that has, limited capabilities, some rural ER.
Absolutely.
And you got a patient comes in there with a STEMI, heart attack,
Stroke,
needs
yeah,
to go to a
yeah.
cath lab. We're probably going to be your quickest asset to get you there.
Just if you look at a hospital like Geauga Hospital, you wouldn't think of as a particularly remote hospital. I mean, they're pretty conveniently located.
Sure. Yeah.
But
Unlike Portage.
yeah,
Out there on an island all by themselves.
Hey, we're the best hospital in Portage County.
You are the best hospital.
yeah.
Consequently, you are also the only. Yeah. So for those for those people that don't have Google Maps, and but I'm sorry, you're saying.
Yeah, it's from Geauga Hospital to downtown by truck is an hour.
Right.
It's a solid hour.
Yep. Absolutely.
You throw in any kind of weather conditions, traffic conditions.
Traffic, yep.
422 coming through Solon in the
Yep.
middle of the
Yep.
rush hour. Now you're looking at greater than an hour.
Yep.
By helicopter, we're talking 12, 15
To
minutes.
say it's a 15-minute run, I imagine.
Yeah.
That's it, and that makes a big difference. And when we're talking, time, in a stroke, time being brain,
Absolutely.
or
Right.
in cardiac, time being muscle.
Trauma in the golden hour.
Exactly.
Yeah.
Getting people to where they need them in the first hour.
You were talking about giving them being the trauma team downtown or at a trauma center, giving them 45 extra minutes to work in.
Yeah.
I mean, that's a lot of time. When you take out, instead of an hour transport, you have 15 minutes.
Right.
That's given that patient a lot more time in the hands of the people who they need to be in the
That are
hands
the best at it. Yeah.
I can even throw a neat little fact out there if, kind of cool to know is if you want to know how long it's going to take us to get somewhere, go on Google, look up straight line distance. You go on a map, you put in your direction, where you're at, or you put in your coordinates where you're at, and you can put in either where we're at, or say you want to know how long it's going to take us to get from your spot to downtown. You take that distance, divide it by 2, and that's going to be our flight time. So we're flying at about at least 120 miles an hour. So take that, say it's a 40-mile,
Run. Right.
40-mile jet straight line. It's going to be 20 minutes. We add a minute to lift and a minute to land. That's 22 minutes. 22 minutes for 40 miles. It's awesome. And that's straight line. That's not winding down the curvy roads.
Right.
Or
Exactly.
getting stuck in traffic or a speed limit that's 55 or.
Yeah, which is practically an hour.
Yeah.
When, to Nathan's example there, which practically takes an hour, despite, let's say you were averaging 60 miles an hour. Obviously, I did math here. I'm proud of myself. What did I say in the last episode? My math is getting better with age. But no, absolutely, it's great.
And
great
those
point
interfacility transports, obviously you do traumas, but
Right.
from out of Portage, I know you guys do a lot of like Impellas, and you do like specialty transports out, like with specialty equipment that's got to go with you, right?
Yeah.
So you guys have to be trained on. You guys, do we fly any ECMOs in our program yet?
We currently don't.
there. Not yet, right.
There's been talks about it, but we currently don't. Our ground critical care team does though,
Takes
and I
that.
know they're excellent at it. So
No, they're-
I'll give them a shout out for that one. They do a great
Right.
job. So
But you guys have to know how the Impella works, how to troubleshoot the Impella, how
yeah.
the vents work, how all these other
Balloon
devices
pumps.
work. Yep.
Yep.
On
To
these critically ill
caveat
patients.
on the Impella, we actually had a rep from Impella with us last week,
Last week.
and he gave us a course, and he came from the flight world. He flew for, I think he said 15 years or something like that, and so he was able to even give us hey, this is what you need to know for flight. It's not, this might be pertinent to somebody who's sitting in the ICU for 12 hours
Right,
that,
right.
we're measuring activated clotting times or something. That's irrelevant to us.
Yeah.
But when you get to the aircraft, hey, this alarm, what's this alarm mean? What's that alarm mean? This is how you troubleshoot it, and that's how you
Right.
fix it. So we're definitely expected to know that sort of thing. We're expected to know about all our equipment, ventilators, like Dr. Hill said, our balloon pumps, number of things.
Real quick, we're talking about these, and everybody at this table intimately understands those things. Like what's the one paragraph on what a balloon pump is, and what the one paragraph on what an Impella is for the audience that would in a pre-hospital perspective would not touch these things.
So in Impella,
Or if they're touching these in a pre-hospital, it's a really, really bad day.
Oh,
Very
yeah.
bad day.
So a lot of the pre-hospital providers, you guys would be familiar with an LVAD.
Sure.
What an Impella is an Impella is a temporarily placed LVAD.
LVAD on a wire.
It
I
is,
like that.
right.
That's a good
It
analogy.
is instead of installing a sub pump in your basement that will pump it out every time it rains. This is the rescue pump. This is the one at the end of the garden hose
sitting in the yard, right?
that
Yeah.
when your basement floods at the once in a lifetime thing that you're going to drop in there and you're going to pump it out. But once the condition has improved and the patient has improved, these are patients that most likely won't get an LVAD.
Right.
Their heart needs rest. Their heart needs help. It needs to get pumped out. And that's what the Impella is. It's basically a sump pump on the end of a garden hose where they put it in, they pump out the heart, they give the heart its relief, but that eventually comes out and that patient recovers and the patient goes home without that device. Where, like I said, a lot of our pre-hospital, they're very familiar with LVAD and get LVAD training every year.
Right.
The LVAD, it does that. But like I said, that is the sub pump that's cemented in your basement, and it is going to be there forever for a problem that happens every time it rains.
Right.
I think another good analogy I got when I was in the CI, when I worked cardiac ICU years ago, that was kind of awesome, was it's basically all it looks like. It looks like a McDonald's straw with a fan in it, and that fan spinning at 40,000 RPMs, pushing the blood. It's an Impella. The reason they call it an Impella is because it's an impeller device.
Impeller, right?
If you think of a jet ski, that's how a jet ski works. It's got an impeller in it, and it's pushing the water through. It's doing the same thing with the blood. Easy enough, yeah.
Just help for the heart.
Yeah.
Cardiology is just plumbing.
Yeah, pretty
Right,
much.
right.
Yeah. The balloon pumps, if we get into those.
Yeah, real quick.
Yeah, so basically what a balloon pump is it's essentially it's a balloon.
That pumps?
Yeah, it's a balloon that pumps. Yeah.
On a pump. Okay.
Yeah, so they come in different sizes, 30, 40, 50 mLs. And generally they'll go through the groin. What they do is they'll go in through the groin and they'll put this balloon in, and they'll use it a lot of times for these STEMI patients where they put this balloon in, it sits between the renal artery and it sits between the
Coronary arteries.
well, it sits
Under the aortic arch.
so it kind of sits
that spot.
right in this spot here, and every time that your aorta closes, this balloon's going to puff up, and what it does when it puffs up is it's actually pushing blood back towards the heart,
yep.
which sounds kind of crazy.
Counterintuitive.
But
Counterintuitive, for sure.
if you think about it, all your coronaries come right over top of that.
Yep.
So all your coronaries that give all that oxygen to the heart are right there. So this is pushing all that blood back into your coronaries, and it's giving your heart extra oxygen, and
perfusion,
it's
yeah.
helping it perfuse,
Yeah.
and helping it work a little bit easier. So yeah,
Those things are kind of tip of the iceberg. There's some really, really cool stuff that's out there as far as cardiac support anymore.
Oh,
I mean,
absolutely.
without even getting into the ECMO stuff, but what can be done today is just becoming so cool. Like if you
amazing.
told me at the beginning of my career you're going to be seeing these things, like yeah, right. That's Star Trek stuff, but
Yeah, with all those devices, always comes along the associated risk of being outside of a hospital.
yeah,
And so that's why we fly a lot of those type of patients, especially
minimize it.
when they're fresh or they have a condition that's going to be, the treatment's going to continue at possibly a bigger hospital or a hospital with a more capable ICU or cath lab, is you want to minimize that out of hospital time.
Yeah.
You don't want to put them in a position where they are going to be 2 hours between a hospital with this device, and you still got an hour to go, and they need
And
help.
risk something happening.
If you could cut that down to 15 minutes and you could put them back into the hands of a cardiologist with a cath lab sitting right there, just in case things become disconnected, things become dislodged, the patient's condition changes. They might have to change the device. They might have to change the size of the balloon.
Right.
All those things you can't do in the back of a truck. You can't even do them in a hospital room.
We're at say, yeah.
So that's the, like I said, we think about time sensitive, and that's why it's time sensitive for us. Is you want to minimize that time in which the doc or the cardiologist lets them go, and the next one takes them on.
We've had changes in the laws recently about billings, right?
yeah,
One of the big things that comes from, especially the emergency department, is we really want two things. We we want to use the minimum amount of resources possible to transport a patient safely, right? If I think the patient can go by ground, I don't want to take an aircraft out of the sky for you guys to do another more critical call. And B, I don't want to stick that patient with a at minimum $20,000 bill just to have you guys take off and land and see the patient, right?
Yeah,
So-
totally.
So talk about what's changed with the laws recently about no surprise billing.
Yeah, so as far as no surprise billing goes, we could get into all kinds of stuff with this.
And we can just broad brushstroke this.
Yeah,
as-
I think it's in a way I know it's made things tougher on air medical, but I
Sure.
think it's made it way better for the patient.
for the patient, exactly.
We're not burdening them with this crazy bill when they, sure, there's an ALS ambulance down the road.
Right.
They called the helicopter because it's faster. But that patient really need a helicopter? Is that necessary? We're saving resources for patients who really need it. We're helping the patient in a sense that we're not burdening them in the long run, and it's really, I think it's good for the system in
Yeah.
general.
Yeah,
And,
so
I guess the high level view of what I think you were getting at there is,
I don't-
insurance covers what it'll cover,
Yeah.
and then the rest of that does not get translated to the patient. So
Yeah.
Right.
that's the big take home there.
The good side is that 6 months down the road, you're not going to get a bill for $20,000
Or
because
whatever it is, right.
somebody on the billing side was late submitting something.
Right.
The bad thing is,
or I
is
didn't
if-
document the actual reasons why I was
Right.
concerned,
Correct.
and
Yeah.
why
Correct.
you needed air medical transport at that
right?
time.
The bad thing for us, and it's cut down revenue and our abilities to pay for payroll and fuel and equipment
stuff,
and,
right.
and the mechanic who comes every day to check that aircraft.
Yeah.
It's cut down on that because if somebody doesn't submit something or doesn't provide reason for transport on time, and we fly, and that flight, you collect 50% of it.
Yeah.
Well, it's not going.
It's not
It's
good,
not
right.
coming out of my pocket. It's
Right.
going to be coming out of our ability to, like I said,
Do the
pay
next
for
thing,
fuel,
yeah.
pay for the pilots, pay for the mechanics. So in both ways, it has cut down on the revenue because you can't add on to that and say, and
right.
which is good and is less frustrating for the patient because nobody likes getting those and bills. But at the same time, a great amount of money and resources goes into a flight. From everything from the dispatch center, which is sitting states away, that is gathering the phone calls, taking the phone calls, dispatching the aircraft, to us, a nurse and a medic who are sitting at the airport waiting for your call.
With a very
and
expensive
the
mode of
pilot
transportation.
sitting
Oh,
there
yeah.
waiting for you to call, and the mechanic who has to come in and work on that aircraft every day,
Maintain it, yep.
no matter if it flies or not. He has to come in here and he has to work on that thing every single day to keep it up and operational and flying. And the fuel tank has to get filled. And
Today's not
that-
cheap.
Yeah, everything
Yeah,
that goes
nothing
into
in air,
it.
no. I mean,
So-
nothing on the ground is cheap. So I mean,
No.
orders of magnitude more to put it in the air. But yeah, I think the previous reticence that existed was, I'm not going to use that asset because it's going to cost my patient money. But that's gone now.
Well, I mean, I'm a new old doc, meaning I trained recently, and that was a part of the conversation we had in my training. To now that's now different, and we've even switched around here at UH as to, okay, we're going to call for transport, and we're going to have that conversation of what assets are available. And while I don't have any other assets available, but the helicopter's available, we're going to send the helicopter just to move that patient.
Yep.
And the broader spectrum of that is if I'm trying to move them out of Portage, well, then that patient then frees up a room for me in the emergency room so I can see the next one.
Next
Or,
guy.
I'm not spending a lot of critical care time on this patient when I can now move them more quickly to their definitive care than having them penned in the ER and have them then decompensate over that hour I'm waiting for transport to show up.
Totally.
When you guys can be
Right.
there and hop the patient over to Cleveland in 15 minutes or 5 minutes to Akron.
Yeah, and it's something that we don't want our pre-hospital people to be sitting there and thinking about. If you have your guidelines of what makes a patient, a major trauma versus, not minor trauma, whether you're working off of like a knots protocol or you're working off of another protocol. But when you have that patient where it's an MVA and someone died in the car, and you're sitting, that now makes their passenger a full trauma.
A full trauma, right?
And we don't want you to second guess that. I don't want to stick this patient with a huge bill when they seem okay. They did fall 25 foot, but they seem okay. If it's major trauma and you can't take them directly
They'll benefit from the aircraft,
right, you can't take them directly to a trauma center in a timely manner, we want you to call. We don't want you to sit there, we'll save them the trouble of coming out. We'll save the patient some money. Don't make decisions based on that. If this was your family member and they fell a couple stories, you'd want them at a trauma center.
Right. Yeah.
You want them checked out. You wouldn't want them at a local area hospital, which now then you're 2 hours down the pathway of care,
getting them to
now things have progressed to the point that the helicopter is now called. You'd want them down there right away, getting the scans, getting the treatment, getting the surgery if they needed it. So we do, when we're talking about billing, especially pre-hospital, don't second guess yourself. If it's a major trauma, if it's a stroke or a STEMI or anything that you feel needs to fly, needs to get to the next level of care quickly, we're there.
But the providers need to know that can be out of their mindset. You can take that financial worry out of for the patient. So.